So without further ado, good morning, everyone. Today we have Dr. Kleiger with us, who is the professor of medicine at Yale University. He's formerly been the senior vice president of medical affairs and chief quality officer at Yale. Before that, he was the chief medical officer of Hospital of St. Raphael in New Haven, Connecticut. He's been the past president of Renal Physician Association. He serves on the Quality, Safety, and Accountability Committee. He's been the past president of Forum of End-Stage Renal Disease Networks, and he's been the chairman of the steering committee of Frequent Hemodialysis Study, as well as the Hemodialysis Novel Therapies Consortium. He has served as the chair of ASN's Nephrologist Transforming Dialysis Safety Project, co-chaired the ASN's COVID-19 response team, and is currently chairing the advisory committee for ASN's Excellence in Patient Care. Dr. Kleiger has received several awards, and we are extremely grateful to Dr. Kleiger for sharing his expertise of how should we do vascular access management and preventing infections. Thank you so much, Dr. Kleiger, for joining us today.
Thank you very much. I really am delighted to be here, Tushar.
Yeah, I know, Dr. Kleiger, we sort of touched upon this, like what we can do as nephrologists or dialysis facilities about preventing infections, and how should we tackle this beast?
Right. Well, the challenge for any dialysis facility is that there are so many demands being made on us. We want our patients to be safe. We want our patients to have normal hemoglobin concentrations. We want them to have bone disease taken care of. There are guidelines now that continue to multiply that we have to adhere to, at least try to. And the real challenge in a dialysis facility is to say, hang on just a second. I have a finite amount of time. I have a finite amount of attention. What really matters? What are the things I really need to make sure that we're taking care of properly? And so some of the background information about infections, I think, are critically important to place infection prevention and infection treatment in that group of things that we have to do. So let me just give you a couple of facts. First of all, 12% of dialysis patient deaths are due to infection. In fact, infection rates are 20 times higher among dialysis patients than age-matched non-dialysis patients. Of bloodstream infections that are reported to the National Healthcare Safety Network, a third of them are due to Staph aureus. And furthermore, among those patients who have Staph aureus bloodstream infections, 40% of them are MRSA, are methicillin resistant. And so the risk to our patients of these infections is enormous. Adults on dialysis are 100 times more likely to have staph bloodstream infection than adults who are not on dialysis. And so as we think about the, infection prevention, it's not just one of those many things that we think about and talk about for our patients. Brian Ra and Shannon Novostad and their CDC team have a wonderful paper that they published last year that says that there are three things that we at each dialysis unit need to do. Number one is to prioritize prevention and optimize treatment. A second is to identify and address barriers to low-risk access placement. And the third is to implement best practice. And so, your first question about, how do we think about this? What do we do? At the dialysis facility, I believe that we have to have infection prevention as one of the major foci that we use. When we round on our patients, that has to be one of the major things we think about, not just their hemoglobin control, not just their bone disease, but what are the specific issues at this facility and for this patient to prevent infections and to make sure that infections are not this high a risk.
No, thanks for at least kicking us off with very important points on optimizing infection prevention. And, what do you think would be some system influencers that we as nephrologists should be cognizant of to optimize infection prevention while we are rounding?
Well, the first thing I think that nephrologists need to do is to recognize who spends most of the time with the patients. It ain't us. we really work as a critical team with our dialysis technicians and our dialysis nurses and our social workers and our dietitians. And unless we're prepared to truly work as a team, to have a strategy to deal with these challenges of infection, we won't succeed. So just the nephrologist saying, okay, here are my priorities and here's what I think you should do. When we make our usually fairly quick rounds through the unit at as frequently as whatever frequency you do, that's not enough. So in terms of influencers, number one, I believe that the leadership dyad of the head nurse and the nephrologist need to have a clear strategy that deals with their specific dialysis unit. For us, what are the barriers? What individual patients pose the highest risk and why? And then what is our strategy for preventing infections and for dealing with these issues, one patient focused at a time? So in terms of influencing, I think we need to think of it as on the micro level. What do we need to do right at the bedside? What do we for each patient? It may not be the same from one patient to the next. So that's one thing that we clearly need to do. The second thing is that the patients themselves are critical partners with us. If we think of them as just passive receptacles that lie on the bed while they're being in the chair while they're being dialyzed, and that we're going to come to them and tell them what to do, we're going to fail. So the second, I think, major influencer is the patient. And what do we need to do to make the patient truly a part of that team? Again, one patient at a time. So that means, number one, respecting the ability of the patient to understand when real data are given to them, when real information is shared with them, and then testing, seeing how well do they really understand or not, and then approaching incorporating patients into what we do based on what their level of understanding is. Some will have very sophisticated, some not. Doesn't matter. At whatever level each is at, we need to make sure that they feel active participation in the work of preventing infection. So incorporating the patient and making that work well. And finally, the last thing in terms of influence, I personally think that we did a disservice many years ago. I participated in this, so I blame myself too. But when we did this Fistula First project, in which we made it black and white, in which we said, you know something, unless you have a fistula, you fail. That's basically the message we gave. We made a bad mistake back then. Of course, a well-functioning AV fistula is a preferable access, but it may not be possible and it may not be practical for each patient. We've all had patients that have had 5 and 6 and 10 efforts to have a good fistula made and they fail, and eventually you need to do something else. We've all had patients who look at us and say, Doc, you're not cutting on me. You're not going to make a fistula in me. It's my body. It's my decision. We know that in order for this to work effectively, patients need to understand why we think of catheter last instead of fistula first. But we also need to respect each of our patients' choices and each of our patients' decisions if they're made well, if they're informed, if we can do whatever we can to make sure they have the facts as we understand them. But I believe that minimizing infections is, again, one patient at a time, using that patient's preferences and that patient's decisions, and then doing what's best.
No, I think I like how you changed the narrative to catheter last instead of fistula first. I think I'm going to latch on to that. And you're absolutely right. We need to personalize according to patient preferences, and maybe the patient's education plays a key role.
Yes, of course, I didn't start the catheter last movement. Very smart people before me have said that, but I do believe that that's the right approach, and I do strongly feel that unless patients are empowered and unless they are making the decisions with our help, we're not making the decision. We'll never solve the problem of stopping infection.
And what are your thoughts on these technological advancements that are there with access placements like ultrasound-guided procedures to create or have improved success rates with accesses, or the endovascular AV fistula creation?
Yeah, so I'm excited about the upcoming technologies. Now, Of course, I'm going to remain skeptical and I want to see data. I want to see what the actual results are, not what the companies that are, doing them and doing small studies to examine them. I actually want to see outcomes. But I'm really excited because up until fairly recently, access was no different when I was sort of in my early years in the 1970s. And now 50 years go by, and the technology is not very different. But in the last few years, endovascular access, novel materials, novel designs, very smart and clever people are now looking at different options and are being examined. And yeah, I'm really hopeful that that will make a big difference. When you put together the new, potentially safer technologies with a more human approach, talking to our patients about their choices and having them decide, I think that that combination is a very powerful one.
No, I agree. And, emerging research and data analytics is important as we adapt to evidence-based practices. So any suggestions on how dialysis facilities could work towards standardizing their procedures and policies, which is obviously rooted in evidence-based practice, to prevent infections or have better outcomes with vascular access?
Yes, great question. And that'll get us to talking about the CDC's 9 core measures, because the CDC has been very careful and clever in how they've guided us on the best way of getting there. Policies and procedures always are designed. Well, let me say 2 things. First of all, I want to talk about human factors. Policies and procedures are always designed by people sitting in a conference room and coming up with what the evidence says is the best thing and saying, okay, let's do this at our dialysis facility. Great intentions, almost always based in good, hard evidence. The real problem, though, is that over the years, more and more of those evidence-based guidances have been issued, and some of them were inspected even to see whether we're adhering to them. Others are there. And the real practical problem is, well, how do you deal with a panoply, a large amount of guidance like that? What we've learned, we did some what are called human factor studies. We went with human factor engineers. The we now is the ASN, and its nephrologist transforming dialysis safety team. We went into a series of a dozen dialysis facilities around the country, and in each one, we observed like flies on the wall. We just sort of sat there and watched what was happening in terms of putting patients on and off the machine, in terms of standard dialysis practices that are best evidence practice that we're all supposed to be doing, in terms of other risks or risk behaviors, injection techniques, hands hygiene. We've just watched what would happen. And our human factors engineers were really interesting in what their observations showed. They showed that there were 2 major problems that happened in virtually all dialysis facilities that impacted the ability of people to follow best practice, to follow best protocol. Everybody wants to do the best for the patient, but when time limits your ability to do everything, and when you're under tremendous pressure as a technician or as a nurse to get the job done, what happens is that we end up taking shortcuts. We do it not because we want to hurt our patients, but because when there are so many demands made, we end up doing shortcuts so that we get as much done properly as we can. The 2 major things that they observed around the country were, number one, what's called task stacking, meaning that nurses and technicians are not doing one thing at a time. They're doing 2 or 3 or 4 or more things at a time. When they're starting to put a patient on the machine and the dialysis machine in the next bay starts beeping when it's in its cleaning mode, there isn't even a patient there, but somebody has to stop the beeping and somebody has to attend to it. And then there means hand hygiene between doing that and getting back to the patient. And at the same time, if a phone call's coming in and somebody has to answer the phone or deal with an issue that's come up, or there's a real urgency in the unit where, somebody starts bleeding or somebody has hypotension. We found that multitasking is the rule, not the exception, and that most often nurses or technicians are doing not two, but more than two things at the same time. Well, the quality, the human factors engineers tell us that that's exactly the circumstances at which people take shortcuts. And taking shortcuts means leaving out critical steps, which in turn translates to higher infection risk. So task stacking, we have to address that and figure out what to do about that. The second major thing they found almost everywhere is that there was lack of clear definition of soiled or dirty and clean. Where things were clean and where they were not clean is not so clear during the dialysis procedure. Is the machine clean or dirty? Is the patient's arm clean or dirty after you've swabbed it, with disinfectant? And when does that be, if it is clean, when is it no longer clean? We can tell you that nurses and technicians and doctors asked those questions, had different answers. They had different responses at different times during the procedure. We don't define in each unit carefully enough how we think about what's dirty and what's clean. So the first answer to your question is that the human factors are really critical in understanding how we do our work and have to be addressed at a unit by unit basis in order to get that work done properly.
Yeah, and thank you. I mean, you're giving me good content here. You said multitasking is the rule and we cannot get away with it, and because of those reasons, maybe they're not following the correct aseptic procedures or the dry times, which are absolutely right, which happens in an ICAR assessment, and those are the feedback that we normally give to our team members. So what solutions came up from two very important barriers that you have found? Before we move on to other factors, I do want to hit more on this topic on how to make multitasking efficient and safe for patient care, and how to standardize what is clean versus not clean.
So the first thing I can tell you is our studies so far don't answer that question. We just did these observational studies, but with a smart group of people that saw that over and over, human factors engineers and nephrologists and dialysis nurses, we had some thoughts and ideas that we think are worthy of testing to see whether or not those really would make a difference. And let me give you some of our ideas.
Thank you.
So the first is this: the riskiest time to patients for acquiring infection is during put-ons and takeoffs, when we are interrupting the circuit, when we are exposing patients' blood to outside things like needles and skin contamination and the hands of the caregivers. So wouldn't it be nice to find a way to make it safest specifically during those take-on and take-off procedures? Well, there's some precedent for that. In the airline industry, in the half hour before landing, pilots have something that's called the sterile cockpit, which means that in the 30 minutes before landing, all casual conversation stops. There is no discussion in the cockpit other than the communication between the tower and among the people in the cockpit, all dealing with the landing. Anything else is not permitted. And in the airline industry, it was found, the evidence is clear, that the idea of having a sterile cockpit reduced mishaps in the air by an order of magnitude, literally an order of magnitude. Well, what if we were to have a similar, it's not quite the same thing, but what if we were to have a policy wherein for the 10 minutes or whatever, 15 minutes of take on or put off, the person doing that work with the patient will have no interruptions, will have nothing else to do but achieving that task. Now, that means that some tasks will have to be reassigned in the unit. It means there'll be some sharing of responsibilities at times that technicians or nurses are not doing the take on and put off. But that's one hypothesis that we would like to test. A second is that there's a priority of things that when you're task stacking, all tasks are not equal. All tasks are not the same. So, for example, when you're taking a patient off, if there's an alarm that goes off in the next bed, somebody else should be taking care of that, not you in the middle of your task. And even if we have a sterile cockpit idea, there are other critical times where you're attending, and the most important thing is what's happening with the patient. If if you start to see some blood leaking, if the patient is complaining of a dizziness or pain, or there's a spot of hypotension, there shouldn't be task stacking at those times. And so we can have ways of having our policies and procedures set out in advance to have ways of alleviating that task stacking at critical times. So those are just, again, it's a hypothesis. It may be right, it may be wrong, but those are the kind of hypotheses I think we need to test.
Thank you. I think it's very interesting hypothesis, and it probably will work because you're going to be more focused and mindful in those critical time points of take on and take off where you think an error could happen. I in this day and age where staff resources is a big issue, I do think piloting it in a smaller project and then expanding it based on the results would be a great start. Thank you for sharing your wisdom on that. And
So just to add quickly to what you just said, we think not only a pilot, but we think a feasibility study is needed.
mhm.
So, given our staff shortages and given the pressures on our staffing and our care, I'm not even sure it's feasible to have this kind of action. Yet, I think that the outcomes are likely to be so impressive that we think we need to do some small feasibility studies first to see if it's feasible. And if it looks feasible, if in a unit or two or three we can figure out how to make that work, then we need a pilot study. Then we need to see whether or not, before it's widely dispersed, whether it really seems to work.
No, well said. I think thank you for giving me ideas here. And I think I could talk more to you about, what you have found out with the human factors. Very, very interesting topic. But let's talk a little bit about the CDC 9 core interventions for our audiences that we need to focus on to reduce bloodstream infections. And how can the facilities, implement and sustain those CDC 9 core interventions?
Yeah. So first of all, I hope that everybody listening knows what we're talking about when we say the 9 core intervention. And for those of you who don't know, it's easy to find that out. You just go on the CDC's web page and you look for bloodstream prevention in dialysis facilities, and it's right there, easily accessible. I have it in front of me right now as I'm looking at it. And there are two pieces to it that are critical. Number one, it's several things that evidence have shown clearly reduce infection. So number one is evidence-based guidance. But along with that evidence-based guidance for each step is making observations in your facility about whether it's being done or not and how it's working. So let me give an example. One of them is hand hygiene. Now, the data are very clear that when hand hygiene is used at the 4 critical times that we've all heard about how do we use hand hygiene, when it is used, infection rates fall. Evidence is clear. We all agree, we all follow hand hygiene. So the 9 core measures include not only doing hand hygiene at the right time, but making hand hygiene observation, having a way in the unit of having a secret shopper, having somebody sort of watch and see if it's being done well or not, and even having patients help us do that. Patients are the ones sitting there who know better than anybody whether hand hygiene is being performed or not being performed each time that they're approached. And for all of us to understand that if a nurse comes to me and says to me, Alan, I'm sorry to say this, but I saw you were in a hurry, and you used hand hygiene when you went to the patient, but then you turned and you answered your phone and went back to the patient and you didn't use hand hygiene again. Instead of my saying to that person, I don't think you saw me properly, that's not what I really did. Instead, if I say, oh my gosh, thank you. I really appreciate you pointing that out. You're right. It just was a lapse. I need to think about how to do that better. If we each can understand that it's so helpful, we're all human, we all make mistakes. So observations and the mental attitude of being open, all of us being open to have our colleagues help us and for us to help our colleagues to do things right and to incorporate patients. That combination of things is really what makes things happen. So the CDC 9 core measures have to do with hand hygiene, catheter or vascular access, care, patient education, catheter reduction, that is catheter last, and what we're doing about that, chlorhexidine skin antisepsis, scrub the hub, which we all know about, of the catheters, and antimicrobial ointment. Those are the evidence-based CDC core measures, but with each incorporating observations and data collection to see if we're doing it or not, and when we're not doing it, to then figure out one step at a time what we need to do to make that observation better.
Right, right. No, thank you for sharing. And, any comments on our patients who have, let's say, C. diff, and, there is that extra layer of protection when we are going to go into their, so to say, workstation, and when we come out, because those are the tweaks that I have observed in my dialysis units. So any sage counsel on that, Dr. Kleiger?
Well, number one is C. diff is prevalent. It's everywhere. If patients have been in hospitals or have been in extended care facilities or nursing homes. So the one thing is, in my mind, I can never say one person has C. diff while another patient doesn't have C. diff if they're at risk for C. diff. So I treat patients who are at high risk for having C. diff as having C. diff, even if we've done cultures and found that somebody's had it but no longer does. In my mind, that's somebody whose precautions I still think of as C. diff precaution. The second thing is that the two most critical things about C. diff prevention are barrier precautions and hand hygiene. There are other things we do, but every time I'm going into a high-risk patient with C. diff, in my head, I have two things in my head. Barrier precautions, am I handling them right? Are we doing that the right way? And number two, hand hygiene. Is everybody handling hand hygiene in the way we really need to?
Right, and thank you for adding that barrier protection, which people can tend to forget, and that is something the surveyors are very mindful of, or everyone else in the team should be mindful of. And you're right about having this growth mindset and working in a multidisciplinary approach. Any suggestions on QI projects that would help us reduce bloodstream infections?
This is the critical point. QI, again, is local. So I can't tell, Tushar, I can't tell you in your unit what a good QI project is to improve infections. But what I can say is that if you're dedicated to collecting data in your unit, and not just collecting checkbox data, not just what we report to NHSN, although that's important. Mm-hmm. But if you take each of us takes a critical look in our units and looks at what's actually happening, that's the lead that tells us where the QI project needs to be. Mm-hmm. When I was the chief quality officer at St. Raphael's Hospital, this was in the hospital now. We did some observations in our ICU, and we found in the ICU that our catheter-related infection rate was the worst in the state. I couldn't believe it. We were doing the things we thought we should be doing, but when we actually looked, we were terrible. And so together with a multidisciplinary team and our head of infectious diseases, we literally tore up our guidance. We tore it up and we said, we have to start. It's failing. Whatever we're doing is not working. So what do we need to do to change that? And we had a multidisciplinary team working on this for 9 months, doing repeated observations, talking to each other, tweaking this, changing that. And we eventually literally were leading the state with the fewest number of infections, with no bloodstream infections in our ICUs that were now over 2 years after we'd worked on it, after being the worst in the state. So I'm firmly believing, and my evidence has seen, that on a local level, if you're committed to look at your own results and then look at best practices and then work with the team to look at those little things that make a difference in your facility, the way your unit runs, the way physical limitations are in your unit, the way the personnel are in your unit, and the way we work. That's what real QI is all about.
That I couldn't agree more, and it is coming from you've led the end-stage renal disease networks, and as you know, we select dialysis facilities and give them QI. And this is exactly right. You have to find your own rate limiting step and make the plan, do, study, act cycles around that. And any words of wisdom around, dialysis access, which, could lead to bloodstream infections and QIs. My problem is, when the patient says, I am not going to get any other access, this is it. And, patient has a choice. How do we tackle with that difficult situation?
Yeah. Well, of course, that's the tough ones that all of us are challenged with. And I guess the way I've grown in thinking about that is this. Number one, it is not sinful to have a long-term central venous catheter. As we know, it's not the best choice, and we know that it's more likely to be infected and clotted, and we hoped that our patients would have better choices. But we can't throw aspersions on patients who have catheters forever. So number one is to get it out of your head what's been drilled into our heads, which is that we have to eliminate all of those catheters. We want to eliminate as many as we can, but there will be selected patients that have long-term catheters. Deal with it. And the patients are telling us, deal with it, because they're not going to do anything else. Now, if you leave aside that population of people, there are also a population of people who would be very amenable to better solutions, but for reasons of not understanding the risk or fear or having the wrong social circumstance to think about it. Again, one of my critical thoughts was a patient that I had that was a Black woman from a disadvantaged background who basically did not believe anything that I said to her about healthcare because she mistrusted it. She was on dialysis. She didn't know how she'd gotten that and why in the world she'd been selected to have chronic kidney disease and had to come in for treatments 3 times a week. She did not trust us. She did not trust the system. And when I told her she needed more operations in order to have a better outcome, she basically said, "Why should I believe you?" So I think you need to incorporate other patients and other assets at your at your disposal to figure out how to best encourage patients to think about their best choices, to inform them, to make sure that they're not scared and not mistrustful, to use the right mechanism to give them the best kinds of information. One of the best for me has been patients in the unit who say, "Man, I'm feeling so much better since I no longer have infections. I have this fistula that really works. I don't know what made me hesitate." They're our ambassadors. They're the people you want to, have come over and say to somebody, "Can I tell you about my experience?" If they're receptive to it, great. If they're not, okay. But patients themselves are often the best tools that we have to help inform our patients.
No, that is very good point. And having a good peer mentor or patient advocate could enhance outcomes, whether it's access management or transplant or other
Right.
things that you may have. And thank you for these are real sharing your story and how we can educate our patients, not just with ourselves but with the whole team and including peers. And having a dialogue about it. That will build trust. I'll come back a little because you had mentioned this in your discussions about NHSN, which is National Healthcare Safety Network Annual Dialysis Event Reporting. And we as facility directors are supposed to do dialysis event reporting and and there are some surveillance trainings that happen around it. So any advice on how facilities could participate in this dialysis event surveillance training? And could you educate us more about the dialysis event reporting?
Yeah. Well, let me say a few words about it. But again, here, what's most important is that I have found that nobody knows about this. If you say, what do you know about the surveillance training that NHSN provides? And if somebody knows what NHSN is, this National Healthcare Safety Network, if they do know what that is, there's the virtual training events are unknown because we don't tend to, I tell the nephrologists don't look at that because we don't tend to think that has anything to do with us. If they're coming in to survey me, let them surveil me. But that's not what this is. So with the understanding that each of us can use our own information to devise quality improvement projects and to really make a difference, that we can be empowered to do the work ourselves. NHSN has organized annual surveillance training, which are virtual training events that are self-paced, that are set up that you can do online, but where there is question and answers available to help you figure out a better understanding of your own NHSN data and how to use it to better solve problems and prevent infections. The last was, they do this once a year for the last few years. The last time it was done was last March. My guess is they're going to be doing it again next spring, though I don't have the date available here. But I would just say, having been through that it's really very helpful. It gives you this very specific understanding and training of how NHSN collects its data, how you can use it, not just look at national data, but how you can look at your own data and compare that to a national sampling and help you understand exactly the best targets for your QI work.
Mm-hmm. And no, thanks for sharing that. And I believe in the dialysis event reporting, you also have to report outcomes.
You do, yes.
And could you let us know more about the outcomes and how that could help serve form QIs?
Well, it's not, all of the behaviors we have are process measures. So the behaviors we have are you using hand hygiene? Are you scrubbing the hub? Are you doing the things we know lead to better outcomes? And they're critically important. They're the process measures. But we also need to look at real outcomes. So how often are patients hospitalized as a result of having infections that are acquired in the dialysis unit? What's the death rate? What is the mortality in addition to the morbidities? Those are not processes, those are outcomes. And so I believe we need to pay attention to both. There was a time that the CDC was really saying to us, oh, no, you need to look at outcomes. And we sort of were focused away from measuring processes. And that was a mistake because it's very clear that what we can affect in the short term are the processes we know eventually have outcome measures. And so we need to be focused and measuring and devoting our QI processes both to process measures and to outcome measures.
Yeah, no, that you're hitting it there because once we focus on the steps or the processes, then we will eventually affect our outcomes, which is good for patient care and health systems. Question, does this only happen in in-center or is it happening in the home dialysis world too?
Well, NHSN, is a voluntary behavior. You have to understand that. There is no requirement for NHSN. Now, there is a carrot, so regulators do want to know how we're participating. And one of the critical measures is always one of the NHSN measures. So we have a strong stick that says to us, you should participate in NHSN. But at its heart, NHSN is a voluntary procedure. And so it is open to dialysis facilities that do inpatient and outpatient work, and even to patient facilities, and there are some, we have one in New Haven, that does only outpatient work, we have a CPD unit that also does home hemo training and only focuses on home training. It's fabulous, but collecting data for those places and using it effectively is also obviously important.
No, I didn't know it was volunteer, and I'll definitely go to my chief medical officer and UVA dialysis and be like, hey, we need to do a little bit of my home dialysis outcomes. I want to know peritonitis and outcomes around peritonitis that happens.
There you go. It's true.
No, I think that's useful because collecting data and data mining does raise a lot of questions. It gives you like a bird's eye view of what's happening. And you're absolutely right. We need to focus on the processes or the rate limiting steps or what we can do at a grassroots level, whether it is us or our team, to eventually affect outcome that are patient specific. So thanks for sharing that. And I know you talked about some patient-specific challenges that we have to overcome, and certain solutions around peer mentoring. Have you noticed any other patient-specific challenges around prevention of infection that have happened in your dialysis facilities?
Well, I'm probably repeating myself, so I apologize. But to me, the critical patient-focused efforts are recognizing each patient's autonomy, each patient's differing abilities to process and understand information, but in each case, honoring a patient's choices, working to use everything we have at our fingertips to help engage and inform our patient. And in the final analysis, always honoring their wishes and working within the parameters of what they think is best for themselves.
Yes, no, thank you. And because I like the idea of you saying we should involve patients in our QI and in our decision making, which, that has been a new change, I would say, which is also being proposed by end-stage renal disease networks. The patients are invited to the quality meetings by the medical director, so they can hear all the outcomes we discuss that surround them. So they are
Right. Well, not only hear them, but where they can give their impression, their response, their potential solutions, because it's gold. It's pure gold. It's not only their own lives, but who is in the dialysis unit watching what's going on all the time? There's only one class of person that is, and that's the patient.
Mhm. No, and I think their input is definitely valuable. And thanks, Dr. Kleiger. You've told a lot to us in this podcast. I think we should have more discussions around your humanistic engineering project. I'm very inquisitive about the hypotheses that you've generated. Any closing words on how we could create this infection-free culture for our audiences before we end the podcast?
The only last thing I will say is to remember that this is a priority. Stopping infections is not simply one of the 12 things that we're trying to do. Heart disease and cardiovascular disease is the only single factor that it causes more deaths than infection. Infection is number 2. And so I think that it consciously has to become part of the work that all of us do each time we're rounding in the dialysis facilities.
Couldn't agree more, Dr. Kleiger. It should be our first priority. And thank you for sharing your words of wisdom around prevention of infection. And if our audiences have other questions or comments, they will have that ability to make comments in our ASN website. Thanks, Dr. Kleiger, for sharing your time with us on this podcast.
Thank you so much for asking me to do it. Thank you.
You're welcome.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.